Dr. Johnson is one of our very respected colleagues and a leader in the AOFAS. She started at Mass General, where she, I believe, participated in the education of Dr. Moon, and is now at the Hospital for Special Surgery in New York. So she is truly a world expert in minimally invasive surgery. So it's great to have her and her approach to these to talk to us about how she got here, how she does it, and then to show us in the lab. So Dr. Johnson, thank you for being here. We look forward to it.
So this is a picture of Lapidus I did probably 5 years ago. Open approach, pretty typical standard incisions. And this is how I do it now. Now, I don't even think we need to describe why it's better to do surgery through small incisions, but for whatever reason in foot and ankle orthopedics, I still feel like people haven't bought in yet. And it's not so much why do MIS, but why not? Why wouldn't you do it? And I think that for a lot of people who've been doing open surgery for a long time, it's hard, it's daunting. You're using totally different techniques, you're using different materials, you have to hold your instruments in a different way and really wrap your brain around not being able to look at the anatomy. But especially for the younger people in the room, and really for Ken and Dan, we didn't go into residency knowing how to do arthroscopy, but we learned how to do it. And now it's a massive part of our practice. So I think that for the residents and the fellows and podiatrists, you can learn how to do this. It's just another skill. We know that there are really obvious reasons why minimally invasive surgery is better. From the very start, I can say categorically without any question that there's less pain. I usually do have the anesthesiologist do a nerve block, or I do a local field block. All my patients get ibuprofen and acetaminophen after surgery. And 95% of my patients do not take narcotics. And this is even with a big 4-foot procedure with multiple toes, metatarsal osteotomies, even with fusion, they're not taking narcotics. And those that do, they average 3 oxycodone 5s total. That's it. So there really is less pain. And compare this with probably your average 20 or so pills with an open scarf or Lapidus. The recovery is faster. Again, no question about it. In most cases, these patients are allowed immediate weight bearing in either a post-op shoe or a boot. Patients transition into a sneaker typically by 6 weeks. And the only real limitation I have for patients is no impact for about 3 months. There's solid data on success. I'm not going to go too much into the data for this. At the beginning, when we first started touting minimally invasive, there were a couple articles here and there. They weren't well done. Now we have these really large studies spanning, 5-6 years of follow-up that really show equivalent or superior results. So there's no question. And this is with, if we combine these thousands of patients who've had good results. And finally, it's better cosmesis, right? I mean, if the foot looks better with smaller incisions, and that's not necessarily the most important part of it, but I'm going to tell you, patients like it better. So you need to change your mindset and need to, think about turning in the saw and handling the burr. And it does take a new mindset. There's no question about it. So let's launch into minimally invasive correction. I'll first show you the chevron Aiken and then the Lapidus. So one of the benefits of the distal chevron Aiken is that you really have a lot of control with the osteotomy. So you can control direction, length, you can planarize the head if you need to, elevate it if you need to. So you have a lot of control. You can easily treat mild deformity, moderate deformity, even severe deformities, again, with a lot of control. I use it very frequently for revision cases. So for patients who come back who've had, prior chevrons many years ago or Lapidus, it's a great revision tool. This is a case of my own where I had an early recurrence of a Lapidus or undercorrection, really, and I fixed it with the distal chevron Aiken and really had a great result. It's important to understand the major concepts, though. And one of the areas where I see people fail when they're just starting to embark on this is they did they are often experienced surgeons who did a course or two, or maybe tried the burr in a lab at the AOFAS, but they didn't ever learn the concepts of why we're doing what we're doing and where the screws are placed and why, and really how to make it successful. So to me, these 4 points when you're doing the distal chevron Aiken are probably the most important. The cut has to be proximal to the MTP capsule. You have to maximize the shift, and I'll show that. We think about this as shifting the head, but really what we're doing is we're shifting the base of the metatarsal medially, and that's where you get your correction. You need to keep a really robust lateral cortical bridge, and you need to place your screws as proximally as possible. So this is a really nice study that Becky Serrato and the group from Mercy did, looking at the capsule of the MTP joint and how it relates to percutaneous surgery. And there is some variation, but they give a nice sort of guideline on where you want to make your osteotomy in order to allow the shift and rotation and everything you need to make the correction. And if you're interested, review the article. It's really nicely done. This is just an example. I'm going to show you guys, by the way, a lot of examples of where I made mistakes, because I feel like I learned the most from my bad outcomes and my mistakes. That's where I really learned how to perfect the technique. So in this case, my cut was too distal. My shift was undercorrected. Let me see if you can see. Okay, perfect. So, and arguably the MTP joint isn't as well reduced because I couldn't get that head over enough and get the shaft lateral enough. And you can tell that I use this big screw for the Aiken because I use that when I feel like I need a little bit more correction, that I'm sort of cheating through the Aiken. So make sure your cuts are proximal enough so you can get enough shift. This is another case where I didn't maximize the shift. So pretty big bunion, and my intraoperative C-arm fluoros at the end of the case, I was pretty proud of. You can see my joints really well reduced. Again, I've got that big screw telling me that I probably felt like I needed a little bit more, and I was pretty happy. And you can see everything looks well aligned. Here's the patient at 3.5 months post-op. And you can see, I mean, it certainly looks better than it did, right? But you're seeing a little bit of a little bit of a bulbousness here and this thickness around the shaft. And what happened is you can see this step off from where it shifted later. So in the operating room, I didn't have that shift maximized. So I didn't lock in the TMT joint. So I'm just going to sort of go over this, saying it in a little bit different way. So when you're shifting this head over or shifting the shaft medially, you want to lock in the TMT joint. So you want this to be on as much tension as possible. Because if not, when the patient starts bearing weight, most patients have intercuneiform and TMT instability, even, to varying degrees, but most of them do. And if you don't lock in this TMT joint and bring the shaft out as medially as possible, once they bear weight on it, the foot's going to splay. And, you can see here that that's exactly what happened. And again, it's not a horrible correction, but it's not perfect. And in New York City, this patient will complain of their bunion being undercorrected. So let's talk about the lateral bridge. So the stability of the construct is this initial lateral bridge here. I just to step aside for 1 second, I'm not going over the technique in the exact detail because I think most of you guys, at least in foot and ankle, have seen it a million times. So I figured I'd skip that part and just talk about more of the nuances. But if what I'm talking about is not making sense, or you want me to go over the technique in more detail, I can do that as well. And I have a video at the end that goes through it. But basically, getting back to this, we think about this lateral bridge. So this is where we made the cut. I've got my shifting tool, and I'm shifting the head laterally and really just trying to maximize the medial shift of the shaft. I need there to be at least 10 to 15 millimeters of lateral bridge here, okay? And if you don't do that, the construct will fail, okay? And this is another common mistake that people make at the beginning. I'm gonna show this in a second with a mistake. And then lastly, your screws need to be proximal. And this is for a couple of reasons. These are 2 early cases, and I see so many of these MIS cases shown on social media where the screws are just way, way too distal. And what happens is when the screws are distal, number one, they're prominent, right? So they're really prominent on this side of the foot. You can't shave away that medial bridge. So look at the width of the foot here. You can imagine if your screw started down here, you could shave all of this bone away. But instead, you've got your screws distal and you've almost created this wider foot for the patient, and they hate that. And in addition, you don't have as good fixation. So this is a case, this was definitely within my first probably 5 or 10 cases. This was a really active 72-year-old guy. I was so excited to take care of him using this approach. And you can see at 2 weeks post-op how distracted his hammer toe is. And that just tells you sort of how active he was at the beginning. But my screws are really distal. I wasn't able to shave down much of the bone there. And here he is at 6 weeks post-op. And you can see I totally lost correction. And what happened here is this lateral screw broke through that cortex. So I really had no fixation here, and the head sort of settled back. And then it sort of heals in situ here. And you can see here's where my shift was initially. In the middle, it shifted, and that's where I lost correction. And probably I either didn't have a big enough bridge, or my cut was so proximal that my lateral screw didn't even make it through the lateral bridge. And so when you see patients back at 6 weeks and you see your loss of correction, this is where it comes from. So again, it's absolutely critical to have your screws proximal and try to get as much of that lateral cortex as you can. So let's dispel some of the myths. And these slides come from my battles with the Lapiplasty guys. And there's a lot of things going around about this type of correction, talking about how it lacks power. Myth number one is that you can't correct rotation. I'll see patients where literally their toe is on the side, it's so pronated. And as long as they have some flexibility at the joint, you can correct the deformity. So this is, I would say this is pretty massive bunions on both sides. You can see how displaced the sesamoids are and rotated everything is. And we ended up getting a CAT scan at 6 weeks. I can't remember, it was for another reason, but you can see that the sesamoids are reduced and the foot has excellent correction, and overall alignment is really maintained. Myth number two, you can't correct sesamoid position. I don't think sesamoid position, for whatever reason, is as critical in this type of correction. And I'm still trying to figure out why. Sesamoid uncoverage is not associated with the recurrence that it is with Lapidus. We see patients years out where the sesamoids aren't fully covered, and there's no recurrence. But I think with Lapidus, if you don't have your sesamoids covered, then you do have a higher rate. And I haven't quite figured out why. But in this case, again, easy to put the sesamoids back in the right position. This is another one where the sesamoids were well corrected afterwards. So myth number three is that there's a higher recurrence rate with the distal chevron Aiken. And this has really been dispelled with some of the great studies done by both David Gordon and Peter Lamb from Australia. David Gordon's in London, where they had these huge series with at least 5 or 6 years follow-up, and they show that the distal chevron Aiken doesn't have a higher recurrence rate than Lapidus. I have so many cases of Lapidus recurring, and mainly because all my partners at HSS do Lapidus. So I see a lot of their recurrences. So Lapidus recurs at the same rate that these do. And this is a perfect example. This is a case of metatarsus adductus where just the wrong surgery in general was done. But again, Lapidus is not a perfect procedure either. These are slides that Peter Lamb from Australia shared with me a couple of years ago. And you can see 6 months post-op how the foot looks, and then 6 years post-op where all that bone has grown in. You could argue that the screws are pretty distal. I think this is when he was first starting to do these procedures. But generally the corrections have held and able to survive the test of time. Here's another example where you can see follow-up 6 years later, and the correction still looks excellent. So what about complications? it's not all rainbows and lollipops, right? Just like anything else, there are complications. There are two really large series that have come out that have really documented these. The first one is from Ettore Volcano. He had a huge series of 274 patients with really good follow-up, and the overall complication rate was about 8%. Now, one of the hard parts in reading any article that talks about complications is one person's complications, another person's, minor complication or major. And so you really have to look through it and understand and try to compare apples to apples and not apples to oranges. So I tried to break this down a little bit. And I think that in this case, really looking at the surgical complications, meaning the cases where you have to go back in on surgery for the patients, removing the CRPS, you've got about, a 7 to 8% complication rate. And I think that that's the same as in really any bunion correction, including Lapidus. Looking at David Gordon's big series, same thing. And he had this extensive complication list. He had things listed as complications like, a prominent scar or really anything he could think of. There were, I think, like 30 complications listed. But in my opinion, the most relevant were the complications requiring surgery, again, due to loss of fixation, due to non-union, loss of correction, delayed union, deep infection, and hardware removal rate of about 6%. But again, this really goes to being equivalent to really any of the bunion procedures that we have now. Even in the severe cases, the recurrence rate isn't even higher than in our standard population of Lapidus, with about a 7.5%. And again, this is a recurrence rate based on radiographic imaging, not on patients' perception of their own recurrence. It's much lower. So the other thing that Peter Lamb identified was that if recurrences are going to happen, they usually happen in the first 6 months. And this is the same with Lapidus. One of my partners, Scott Ellis, has shown this a couple of times, that if you're going to see a recurrence, it generally happens in the first 6 months. I would say that these aren't recurrences, but really undercorrections. And if I'm critical about Peter's x-rays, I think he just didn't get enough shift here. And that's why these recurred early on. And the same with Lapidus. Generally, if they're going to recur, it's just that they're undercorrected at the beginning. And you can see at the bottom, the 6-month x-rays and the 6-year x-rays look almost identical. So personally, I try to keep track of all of my complications. I have my own little mini database. I remember each and every one of them because, as we all know, complications can be devastating. I had 4 skin burns at the very beginning, and this is when I used tourniquet. And I was using the little spout on the end of some of the companies have this little spout on the end of their burr that delivers some irrigation. It's absolutely not enough. You cannot use tourniquet in these cases. You're going to burn the skin and you're going to burn the bone. And you can't rely on that little spout. You need copious bulb syringe irrigation anytime you're using the burr. That's absolutely critical. I've had a few superficial infections that are treated with PO antibiotics. I had some asymptomatic undercorrections, about 20. And by the way, this is, I think I'm about 550 to 600 cases now of the percutaneous chevron Aiken. So this is out of my own personal big series. I've never had a DVT or stiffness or this sort of random pain. Now, looking at my complications requiring surgery, I've had to do 2 revision Aikens for overcorrection. I've had to do 1 IND on a patient. I've taken out a lot of screws. I've taken out a lot of the distal screws. And sometimes I think that might be my patient population in New York, where they're trying to get into different shoes than maybe the rest of the world. I seem to take out more hardware than my sort of colleagues who do a lot of MIS. I have seen some non-unions. I'll show you a couple of examples that walked into my office this past couple of weeks. Initially, I fixed my first 2. I open plated them in bone graft. And I now know that that's not the way to fix these. They take way too long to heal. And I can fix the non-unions percutaneously and they heal much faster. I had 3 recurrences that required surgery, and 2 of them were revision surgeries, or probably I should have done a Lapidus initially. And then I have 4 recurrences in my Lapidus group that I was able to revise with the percutaneous chevron Aiken. So when I think about complications unique to MIS, I break them down into 2 categories. And I think about one is rookie mistakes I made early on in my practice where, I just didn't have the experience. We talked about the using tourniquet and not copiously irrigating, and that can result in non-union or skin burns. Under correction, where I just didn't get a big enough shift. Loss of correction, and this is that example I gave you where the screws broke out of the lateral cortex. If there's medial prominence afterwards, sometimes you can be a little wimpy taking down your medial eminence. And then prominent hardware, I really try to sink the screws, and I always use beveled screws. And then some persistent mistakes that I make, you see some recurrence to the TMT joint. And, I think I pushed the envelope a little bit too much on this now, and I'll show an example of that. And then hallux varus, this is one of the 2 Aikens I had to revise. I have a tendency on the right bunion to over supinate the head. And so now what I do to make sure that I don't leave the operating room until I do sort of a flat plate simulated weight bearing and make sure my alignment is perfect. And I take out the Aiken screw and refix it, probably one every, 20 or 30 bunions. So let's look at a couple of these complications. The next 3 I'm dealing with right now. So this is a guy, he's a cardiologist, of course, at New York Presbyterian, which is our sort of sister hospital. I had done his other side, it healed great. He was so happy, and a mild bunion on the left. And so he said, sure, let's go ahead and fix it. Here he was at 6 weeks post-op. He did great. Didn't come back for his 3-month visit. Didn't come back for 6 months, and then came back in at his 8-month visit. This was last month with a clear non-union, right? We see like sclerosis along the edges, and he broke through that lateral cortex, right? I don't have that shift anymore. He didn't heal it. You can see that sclerotic bone on top. I should have a picture. His foot just remained swollen. And that was his biggest complaint, actually, not so much the pain, but the swelling. So last week I took him back and I went through my medial incision again here, and I just basically roughened up this whole area. I didn't want to shorten him. I didn't want to if I did this open, I would have had to put a iliac crest bone block in there. I didn't want to do that because I had done that in the past and it takes forever to heal. So I took BMAC, and then through my BMAC incision, I can minimally invasively take dowels of iliac crest using the Jamshidi needle, or even like a small drill sleeve, and take a few dowels of iliac crest, mix it with the BMAC infuse, and then some DBM, and I pack it into the space there, and then I find new tracks for my screws, and then I added this extra 3rd screw, and I felt really good about the construct afterwards. He wasn't too short, and it felt really stable. So hopefully it heals. This is another one. This is one that you just regret the day this guy walked into your office. So 62-year-old, really active guy, he had gone to see one of my partners, and they told him the only surgery you can have is a Lapidus. So he came to me, I don't want a Lapidus. I want the fastest recovery possible. I want to be playing tennis in the Hamptons this summer. I get a CAT scan pre-op on all my patients, and you can see there's this massive instability at the first TMT. But I thought, well, it's just in one plane, I should be able to fix this. The sesamoids are really rotated, but he didn't have a lot of pronation. So I did the chevron Aiken, and I did at the same time a bunionette correction, and it looked great. I was really happy about it. I got a massive shift. It felt really stable. I since did his other side, and then he came back at 12 weeks, and this is what it looked like. And you can see all of this not normal hypertrophic bone, and I got really nervous. And then look at the lateral. The head's dorsiflexed, screw broke. This is the first time I've ever had one of these screws break in any of my patients. And And now, you know, we're trying to decide whether or not we want to revise this or let it heal and then revise it later. So I think for me, the lesson learned here is this was just way too unstable. And if you look back, there's so much tension on that TMT joint, you know, that it gapped more post-op, and I just put too much tension through that screw. And it was just a real mistake on my part. The other thing is, if you're going to do a bunionette at the same time that you do a chevron Aiken, be very careful, because the patient can't offload the bunion on the lateral side of their foot. So they end up putting more pressure on the medial side of their foot. I really don't like doing the bunionette at the same time, but this is another example of where it failed. So then here's another one that I'm dealing with right now. 80-year-old, pretty frail woman, cannot find a pair of shoes. You know, she just wants to walk her, 10 blocks around the city. So I say, okay, fine, I'll do the procedure. Felt really good about it. Got a big shift. The foot looks really good. Here she is at 6 weeks post-op. And basically what happened is the entire head collapsed, screws came out. You can just see it broke through the lateral bridge. She had she just didn't have the bone to support the correction. And so now just waiting for this to heal and then figure out a game plan from there. I mean, you can see on the lateral lateral image here, just the entire cortex just blew apart. So, what I would have done differently here is probably put her in a wheelchair for, I don't know, maybe 3 or 4 weeks, let this solidify before letting her walk on it, or just tell her to go get a bigger pair of shoes. So those are the ones I'm dealing with right now, which has been challenging and keeping me up at night. But thinking about just in general, percutaneous doesn't just mean a distal correction, and some of these do require a proximal approach. This is a case, where there's this plantar gapping. This to me requires a lapidus about 95% of the time. And so for these with that big plantar gapping, I'm doing a percutaneous lapidus. I've had a lot of success with them, been really happy with. I'll just go briefly through my technique. I take a 3 by 13.1 wedge burr and clean out the joint under fluoro. There it is, where it's sort of irrigate all the bone out of there. Put percutaneous wires in to fix it, put my screws across, and then I put a Liz spring screw in to sort of stabilize that intercuneiform instability. And I've been pretty happy with it. These are just a few cases that I've done and seen back recently, or patients have been super happy. So what about other indications in the forefoot? So we'll move away from bunions for a little bit and talk about hammer toes and things like that. This is a crazy slide. I'm not going to go through it. This is David Redford gave this to me. There's a million things you can do with the toes with soft tissue and bony corrections and realignments that I've been playing with over the last couple of years. At the very most basic, with simple, mild, flexible deformities, you can simply release the extensors. And if you do this through a very small incision within the extensor hood, the tendons lengthen, but they don't completely separate, and so you don't get that floppy toe. So it's a really nice way to treat just a slightly elevated second toe, through a tiny incision, and really requires no treatment afterwards. This is a case where it really, really worked well, where I just did the tenotomy of the long and short extensor, and the toe really popped back nicely there. And again, you can still see there's a little bit of tension here on the tendon, and that's because it's still it hasn't retracted completely, because it's still within the extensor hood. So there's a ton of osteotomies you can do, and you can make these up as you go along. These are some of the early ones that I've done that were taught to me. With the sagittal deformity, you can release the flexors at the PIP joint, the short flexor, as well as the long extensor. It's really important to know your anatomy of the toes, because if not, you're going to release the wrong tendons and patients are going to get floppy toes. And then you can take osteotomies, from the plantar aspect, do a little plantarly based osteotomy of the phalanx, dorsally based osteotomy of the middle phalanx, and then, kind of green stick them down and you get a nice correction. These are images from my mentor in this hammer toe surgery, Barbara P. Clay, where she demonstrates how you release the plantar plate. It's actually hard. It's hard to get the beaver blade in the right spot. I recommend that before you do it in a patient, try it in the lab just to understand kind of where the tension is and how to feel it. But it's also important that you just release the short flexor that attaches at the middle phalanx, because if you release both of them, again, you get a floppy toe, and patients aren't happy with that. Let's see if this rolls. This is just an example of kind of where I make the incision to do some of those plantar osteotomies, as well as the releases at the PIP joint. And then for coronal deformity, these are actually really easy. Again, you're just doing these kind of closing wedges in the direction that you need. And they're great, especially if you're dealing with kind of minor deformities or in elderly patients. It doesn't make up for a malaligned MTP joint. I'll show you a couple of examples of that later, but for just small corrections, this works really well. And you can do it either from the bottom of the foot, like I'm demonstrating in the video, or you can do it from sort of the medial or lateral side of the base of the toe as well. And then afterwards, this is me green sticking it, and it looks a little harsh, but the toe goes in a straightened position and it works really well. It makes a nice crack. This is just an example of where I did the proximal phalanx osteotomies and just got a nice, easy correction. For crossover toes, this oblique osteotomy can be life-altering, and the reason why it works so well is because you're shortening the toe, so you're decreasing the tension on all of the tendons, and so the toe shortens and then moves laterally. So it's a really nice way to fix to correct the deformity. You can see a lot of shortening there. This is an example of me doing it after I'd fixed this person's bunion, and you can see just through that small incision, I made that oblique cut and then just sort of manipulate the toe, and it sort of shortens and sits where it wants to sit. Here are just a couple of clinical examples where it worked really nicely. This is a case of a woman who had, I think, 4 or 5 surgeries elsewhere, and really her biggest complaint was just that second toe crossing over the big toe. Again, just did these little percutaneous osteotomies. I don't think they ever healed. Actually, I followed her for a while, but she never had pain, and the toes sort of stiffened up and stayed where they are, and she was really happy. For rigid deformities, I still do PIP joint resections and pinning or screws. Sometimes if I need to shorten the toe a lot, I still do these open. But if you have a toe that's not long and has a rigid deformity, you can use the burr to debride the joint, and then place your fixation across. And then, I'm holding the reduction kind of any way I can. Sometimes I'm using pins. Sometimes I'm using my dressings. I use sutures in clever ways to kind of hold the toes in certain areas in order to hold the correction for a couple of weeks, up to 6 weeks. And then I use pins not infrequently. And it really does, it makes it a little bit easier post-op. This was a complication. So this was a pretty sick patient and just really needed the toes fixed. So I tried an easy solution, just doing that kind of percutaneous oblique osteotomy. And initially I was really happy with it. And then she came back and had a recurrence. And basically it's because I didn't address the MTP deformity. So you can shorten the toe and it can look good for the first 6, even 12 weeks. But if you don't correct the pull at the MTP joint, these are going to recur. And the people that are showing you, that are showing these images of all of these little aconettes and these, percutaneous phalanx corrections without correcting the MTP joints, they just haven't done surgery long enough, so they haven't seen their recurrences. So just keep that in mind when you're seeing these images shown at AOFAS and other conferences. So I ended up having to go back. I did a metatarsal shortening and then got it to sit where it needed to. You can treat dislocated hammer toes this way. Again, I address the MTP joint. So I did a percutaneous shortening of the oblique of the proximal phalanx as well as of the metatarsal, and pinned it, and it shortened it, took some of the tension off, and eventually it heals. And these will work. This was a case where I couldn't reduce the MTP joint, right? So if you can't shorten the metatarsal percutaneously, you have to do it open. And so I just did it open. I coupled it with my percutaneous bunion, but I did it open. You know, and you can get a little bit creative here. I did sort of these opposing oblique osteotomies for this woman. And, you know, she did great and healed up really nicely. Again, though, I had to make sure that MTP joint was straight before I left the operating room. So metatarsus adductus, this is a dreaded deformity that has, I don't know, a 50% recurrence rate. Low patient satisfaction. Patients think they just have a bunion, but it's not. It's this windswept deformity of the toes. The metatarsals are all going medially in the same direction. The toes are all going laterally, and you don't have a big IM angle, so it's really hard to correct the bunion. So I tried to play with this a little bit, and I tried to correct this just doing those little proximal phalanx osteotomies. It doesn't work. They recur. I promise you they will recur. And what happens is the toes, see how they just sort of fall off here, and then the toes eventually drift, and then the big toe follows. So you have to correct the MTP joint. So this is what I've been doing recently. It's time consuming and a pain in the neck to follow afterwards. But basically I start with an oblique osteotomy, the proximal phalanx. I release the MTP joint, I pin and keep that MTP joint reduced. Then did the same thing with the second toe. And then I cut the, this is me doing the metatarsal osteotomy, cut the, you know, these oblique osteotomies, the metatarsals, and it allows the heads to shift laterally and the whole construct to shift laterally. Then you create a larger IM angle and you can correct your bunion, and you get a much better and more clinically stable correction. And this is an example of one. And then this is a really severe case where in the past, I would have fused the MTP joint and done a huge open approach. The patient would have been really stiff. And, you know, you might look at that and be like, wow, there's some recurrence. But for metatarsus adductus, this is a massive win. And look at her range of motion afterwards. You never get that when you do open shortenings. This is another case where it's 6 months. She's pretty well corrected. And the osteotomies are almost healed. So I'm shifting away a little bit from the bunion and the lesser toes, and we'll talk about some other applications of MIS where I really think everybody should be headed. I get if you don't want to do the bunions, but this is, in my opinion, you should never open up the first MTP joint to do a cheilectomy. So you look at the traditional approach versus the percutaneous approach with that one single incision, and recovery is so fast. You have the same indications as an open procedure, right? So, you know, they have pain with dorsiflexion, there's dorsiflexion, there's dorsal impingement. You know, somebody doesn't have a dorsal spur and they don't have symptoms related to that spur, you're not going to do a cheilectomy. But I will push the envelope here. And in some of these cases where I would have done a fusion or just refused to do a cheilectomy, I'm pushing the envelope on the percutaneous procedure. This is a case of an elderly patient who literally couldn't put a shoe on. And, you know, 99 times out of 100, somebody's going to offer this patient a fusion, but she didn't really have any pain except where the shoe rubbed on the bump. So I just do a percutaneous shaving of the area, and she's totally happy and back in her shoes. I didn't fix her arthritis, but I made it so she could put a shoe on. So, you know, you do 1 or 2 little keyhole incisions. The surgery takes 20 minutes. They have a soft bandage on for 3 days, and then they go back into their sneakers. There are no pain meds. I have patients who come in at their 2-week appointment to have their stitch removed, and they've already been running or back in their Peloton or back in their work shoes. For my younger patients with less severe hallux rigidus, I add an MTP arthroscopy, and I just feel like I get a better kind of clean out of the joint. When the joint's already totally trashed, I don't worry as much about some of the debris that you create with the percutaneous approach, but in a case like this, a 33-year-old, I'm definitely going to scope the joint. It also gives me a good sense of what the joint itself looks like, and I can show the patient. So what about calcaneal osteotomy? So again, why would you ever make this big incision when you can do the same operation through the small incision? It's just, it's not even worth a discussion, honestly. The calcaneal osteotomy, there are multiple papers that show you can get as much of a shift as you can if you do it open. They heal faster. The complication rate in this study by Volcano is about 3%. I thankfully haven't seen any transient neuritis, but this was a lot of he had seen a lot of patients. I don't think I've done 120 of these cases. But really the infection rate is really minimal. And you compare that to the open approach where that wound can take forever to heal. You have to couple it with other procedures. There's skin breakdown, sural nerve injury is much higher. The Zadig osteotomy is has been around for, I think, about 60 or 70 years, but it's gotten a new resurgence of popularity in the minimally invasive world. And this is for patients with insertional Achilles pain or a large Haglund deformity. And what you do is you're taking a wedge out of the dorsal calcaneus, and you're basically changing the trajectory of the way the Achilles pulls. This is a great article for anybody who wants just to understand the concept of the Zadig better. It's a pretty simple article, but it has a lot of really great figures in it. I highly recommend it. You take this dorsal wedge out, plantar flex the foot, and then it closes down. And so you're shortening the calcaneus a little bit, but you're shortening the lever arm, so you're taking that tension off of the insertion, and it works great. And they heal much faster than doing big open approaches. This was just a patient of mine where I did bilateral recently, and I also did arthroscopy to shave down the Haglund at the same time, and he's been really happy. So just to summarize and finish up here, what I've learned through all of these is that you have to take clinical pictures. Do you guys have Epic here? So you can take a picture through Haiku right on your phone. You guys know how to do that? I have every single patient I see for any deformity stand up, I take a picture, it's more immortalized in their chart. So when they come back, I can show them the before and after. It is so critical. And if they start complaining about small things, I can like, remember what your foot used to look like? It makes a huge difference, but it also helps you see what you're doing when it works. You also see what the foot looks like at 2 weeks, 6 weeks. When I first started, I was taking pictures all along the way, so I really had a good understanding of what the foot is supposed to look like. The PICA or percutaneous chevron Aiken is not a procedure for every bunion. I've shown that now a couple of times with my complications. There are still indications for Lapidus. You need to have meticulous technique, copious irrigation, aim for the biggest shift possible. And this flat plate every case, what I do is I try to simulate weight bearing. We had Jonathan DeLand made these beautiful plates that we have in all our kits at HSS to allow for that, really to evaluate the foot really nicely to simulate weight bearing. But you can use the top of any tray for this. Make sure that your correction is adequate. Make sure there's no supination or pronation. Highly recommend that. Radiographic failure does not equal clinical failure. So some of these x-rays look totally wacky or look like there's recurrence. If the patient's happy, you're happy. And you have to manage the expectations. I've been really happy with this. It's absolutely changed my practice. I don't do any advertising, and I could literally, every single new patient that I see in my clinic is a surgical patient. It's just changed the whole dynamic of my practice. It does take about 50 before you feel comfortable. I continue to utilize my mentors for help, and I still learn from every single case. And finally, even if you don't want to do the bunions, which I get, they're hard. Sometimes, you know, it's hard to sort of visualize that shift. Can I really do this? Does it make you fearful? You should always do an Aiken percutaneously, a calcaneal osteotomy percutaneously, and a chilectomy. There's no way that anyone can talk me into those procedures having better outcomes open. There's just not. So at the very least, learn how to do that. Thank you.
Oh, that was fantastic. I think we have a few minutes for questions.
Yeah, questions. And if anybody's interested, I have a video that I'm happy to send anyone. It's like a 5-minute video of me doing the procedure. So we don't have to show it now, but I'm happy to share it if anyone wants it.
Actually, I think we would appreciate that.
Do you want to see it? Or look at it after or in the lab? It's up to you.
It's easy to pull up.
Yeah, it's right. It's my next.
I think that might be a nice lead into the lab also.
Yeah. I tried to make it go faster, but I don't know if it did. Tell me if you want me to stop. So this is just the setup of the room. So the C-arm, I'm a right-handed surgeon, so the C-arm's on the right side of the table. The foot is hanging off the bed. I have the C-arm at the end. You can see that foot off the bed. I'm confirming my position for the osteotomy and just making sure that I like it. I spread directly down to bone, and I'm going to lift the capsule off of the medial eminence in a second. I'll show you. There's a Novastep has this really great elevator, but you can use any sharp elevator to do it. You can see I'm sort of scraping, trying to lift up that capsule, that kind of gritty material off, because I usually shave the medial eminence at the end of the case. But if you take the capsule off first, it just makes it much, much easier. And then here I'm confirming the burr placement, again, making sure I'm proximal enough, but not too proximal. And you can see my PA bathing the burr in the with the irrigation, and just a really simple hand technique where I'm doing the dorsal cut. And you can do a chevron or a vertical cut. It doesn't matter. The results are the same. I've done both. So there shouldn't really be an argument about whether to do a chevron or just a straight line.
How dorsal is your start?
I usually do it right in the middle. Maybe a little bit more dorsal. I don't think it really matters. Look at my left hand. My left hand is feeling the burr underneath. So it's helping to guide. It's definitely two-handed. It's helping me to guide where the burr is, where my hands are going. And this is just me doing that kind of plantar limb.
And are you ever shaving down, like I know you elevate out the capsule immediately, and then you shave down immediately?
I do that at the end. I used to do it sort of midway. I do it at the end because you don't know how much you're going to do. And it's nice to have an extra lever arm to shift the head with that few millimeters of medial eminence. So this is me just getting the correction, and I'm using this device I call the bullet, or it's a shifting tool, and putting it down the shaft to shift that head over.
Looks like you actually put it on the other side of the shaft.
That one I just used a stretch. I'll show you that, but I usually use just the shifting device. I make one incision. I make a 1 centimeter incision at the base of the first metatarsal. I just think it's so much easier than making an incision first or doing it percutaneously. You just make your incision and then put your pins in. Now, this is important. I'm checking to make sure I have enough shift, right? So I'm checking I'm like shucking the first TMT joint. I don't want any motion at that TMT joint. And that's how I know I have an adequate correction. Measuring the screws.
And your eyeball, this you don't have to jig.
I don't. There is a great jig. I learned how to do it without it. So to me, the jig, I don't use the jig.
You don't pass the wires first, or you like start the
It makes absolutely no sense to me. How do you know where the head's going to be? Makes absolutely no sense. Yeah. So I shift the head and then I aim my wires at the head.
And how are you? So you mentioned correct rotation. Are you're just rotating that distal?
Yeah. So I use my left hand and I'm supinating and putting the toe into varus.
If you're able to get a rotation on chevron.
Yeah. Yeah. When I can't get the rotation, it's when you make your cut too distal. It doesn't have anything to do with the cut itself.
I noticed on one of the cases.
This is the medial eminence, by the way, I think.
Showed that the pins were in place when you place the pins first.
No, no. So that's what she just asked. I don't. I get my shift. I put my pins in, and then sometimes I want more of a shift. And so I'll play around with it a few times. I take out that little spike from that proximal incision. And then this is the medial eminence at the end.
Presumably you shave down some of that proximal.
I do, yeah, I think you missed it, but yeah, I take out a huge chunk and I take that piece out from the proximal incision. And then this is the Aiken at the end. Again, I'm using that my left hand to really feel where the burr is and to have a good sense of it. Copious irrigation, it's just so important. And usually there's more bleeding. I don't know why there's not as. I must be cleaning it up because it's the video. Usually it's like a puddle on the floor. I put blankets on the floor so I don't have to worry about the irrigation going everywhere. We always put blankets on the floor. And then here I am putting the toe into varus. And then I put my wire in. I do this wire percutaneously. It's an easier wire to place, so I put that in. And then I make an incision on top of the wire once I like my position. Again, there's my flat plate. Do I like it? Does it look good? Is the toe supinated? Is the toe pronated? Is there enough correction? Do I need to redo my Aiken and get more correction? Measuring the wire. And then put the screw in. Put all the screws in on power. If you put them in on hand, there's a lot of torquing and you can move things around. It's much easier to hold your reduction and put the screws in on power. You know, you do your last few turns to make sure that the bevel's in the right spot, but you really want to put these in on power. Much better control. 2x12. But if I want, sometimes I'll put the wedge burr in there to get a little bit more if I need a little more correction. And then I think that's it. Let's see.
Versus transverse taken.
You could do that. It doesn't matter. I just think it's easier to put the screw in this way, you know, but I started out doing a transverse. You may have seen on a lot of my other video x-rays that I had the transverse. This is afterwards. I take a 16 or 14 gauge angiocath, irrigate a ton, and then again I always check my alignment at the end. I use nylon sutures. I use bacitracin and adaptic, but I don't know why. Yeah. The plastic surgeons used it. Yeah, exactly. And then I use a wet dressing. So you moisten the gauze and wring it out. So your gauze is wet and it allows a really nice compression, kind of holds things in place. I use a cling and then a Coban, just from the midfoot to the basically metatarsal phalangeal joint, and that's it.
What's your post-op?
So they are non-weight bearing while their foot's numb. So basically like 24 hours. And then their weight bearing is tolerated in a boot. You could do a post-op shoe too, but I do a short boot. Oh, yeah, sorry. So they're on that. So for the first 2 weeks, they elevate, you know, you try to encourage them to elevate. I always say 80% the first week, 50% the second week. They come back in, they get their stitches out, bandages come off. Sometimes we have them use like one of those, you know, like bunion splints at night. They can transition into a sneaker, usually around 5 weeks post-op. I see them back at 6 weeks. We get new weight-bearing x-rays. And then from there, as long as everything looks good, I let them do anything they want except running or jumping. So no impact until 3 months. I see them back at 3 months. Yeah, right away. That's the whole point. You want them to weight bear. That's the whole design of this. That's what makes this the greatest procedure ever.
Other questions?
Lateral release.
Oh, great. Such a good question. Probably do a lateral release in 1 out of every 20. So what I do is after I do the shift, if I really feel like there's just, it's a feeling. There's just a lot of tension. I'll do the lateral release. You know what, though? I don't think it makes a difference. I haven't figured out if it makes a difference yet. It seems to be based on this like weird gestalt that we have that's based on no data, and no one's really followed it up.
So I did ask, I noticed the one,
Yeah, you just cut them and let them fly.
you know, I'm dabbling in leaving them. I pin them just because I know that it's there. Then I had a patient who just take her pin and I pull it out, she healed fine.
It's like a dancer's fracture, right? Do you ever fix a dancer's fracture?
No,
Never.
but I worry about malunion.
Have you ever had a malunion of a dancer's fracture?
Yeah.
Have you? I mean, I haven't. And the bunionite heals really reliably. I had to revise one in an elderly patient who didn't heal.
Well, I didn't even notice that you showed a number where it didn't look like there was great bridging, some calluses, so it's probably stable.
Yeah. No, I mean, it's great. You just have to be really careful doing it in the setting of the bunion, because they don't, then they put more weight on the bunion itself on the medial side of the foot.
Well, you could speak maybe, because I was interested in the metatarsal and proximal phalanx osteotomy. Nice correction, nice short. Is there like a gap tolerance? Because I noticed you were doing the oblique osteotomy. You're actually pulling the whole way.
Yeah.
And so almost distracting it. Is there an amount that you won't accept for gap?
No. No, and you can have 100 in metatarsus adductus, you get 100% displacement of the metatarsal heads. I think that when you have that, they heal, but it takes a long time. And so the patient's foot is swollen for like 3 to 4 months, and you have to warn them of that. Now, if you had done the procedure open, they'd be swollen for that amount of time anyways, right? If you shortened all the metatarsals, they'd be swollen for a long time. But when they only see these small incisions, they get very impatient. But you just have to warn them.
And I want to just, well, first of all, that was fantastic. So much.
You're welcome.
I also wanted to say I appreciate that you really focused on complications very specifically, because this is, this is a leap of faith, right? So we have all categories. We have fellows who are learning technique, students, residents who are interested in any level of people who are doing this on some level and want to maybe grow that into practice. But the complications are real, they're scary, and that could turn you off of this entirely. If you have a bad complication, then you're going to say, no. So be mindful of that, really focus here in the lab. I also want to, I did not say this again, I want to thank Invasive, Lauren Will, probably doing this today for supporting us. They supported Dr. Johnson's travel and the lab here today. So I want to say thank you for that. I think the commitment to this technology, we sure appreciate it. And with that, unless there's other questions, I wasn't able to check online.
I'm looking, I don't see anything that's popped up. Yeah, and just one thing quickly, just in the lab, I'm happy to show you anything you want to see. I think Garrett and Tom also brought these really cool radiolucent screws that I use now a lot for some of the percutaneous stuff, so you can, for better or worse, see how things are healing. Sometimes you don't want to see, but they're really great. So do we have them, guys, to practice with? The carbon 22 screws, the Crete screws?
And Garrett will be happy to show you.
Great.
But the one thing that I wanted, if you don't mind, to introduce Garrett Malden, who's our head engineer for our company, which is a small startup company. And the reason I introduced Garrett is for those of you who are interested in all sorts of foot and ankle hardware, including TTC rods and this ankle fracture set and this cool screw. So you may want to take them aside just to talk to them about what the elements of biomechanical engineering is, the engineering component as it relates to orthopedic surgery and foot and ankle. So I thought he'd be a great resource for those of you who are interested
whether you're just starting off or whether you're fairly senior, he's just fun to talk to. And he lives here in Denver. So, thanks for being here. Yeah. All right. Well, that was thank you.